I will cover many of the things that he's spoken about with a slightly different perspective, but with very little disagreement. However, I'd like to start really from a basic principle that if you're doing a GI physiology test, that you need to report it in a way that's useful for the clinician who's ordered the test. And sometimes that's your supervising gastroenterologist or surgeon, but other times it's not. And I think it's really important when you're reporting your function tests to adapt the report as well as the test to the patient's circumstance. The job is to provide accurate numerical data, but also to give some degree of expert interpretation, and of course that often requires team working. So if this audience that we have here is very mixed, so some of you are scientific GI physiologists and may not feel comfortable giving clinical advice, but the report from your laboratory should do so, because you should collaborate with your medical colleagues so that you produce a joint report that's got both accurate technical data and useful clinical interpretation. And that interpretation should give guidance on the avenues of therapy. You don't have to just make a specific decision about whether it's medical or surgical therapy, but it's useful to give the readers of your report some idea as to what the outcome is, particularly if it's not come from a GI physician or surgeon. So your respiratory physician or your care of the elderly physician may have sent this patient for a test and they don't have the range of knowledge of the outcomes. So it's really useful if your report can include the avenues of therapy for the conditions that you might describe. And the interpretation of manometry is an art and a science, and this is a quote I say from a physician friend of mine called John DeCasticker. The science is naming the manometric abnormality and also understanding the numbers, because there's an awful lot of numbers in those reports of impedance, pH monitoring and symptom association. And the art is, what does it actually mean? And it's really important to understand if what you found in the science fits the symptoms, and then if those symptoms are there, are they transit abnormalities, and is it a treatable disorder, particularly with manometric findings. Sometimes we find something, but there's nothing much we can do about it. In terms of reporting standards, make sure your reports are structured very clearly, rather than a waffly essay. So a clear name and demographics, and the date and place of test. Many of these patients have repeated tests over time, and it's really useful to know who did the test, when they did it, where they did it, and why they did it. So the reason for the test is particularly important. List the tests that were actually performed so that the reader of your report has an idea as to what the results are going to be, and then give the listed results in some kind of ordered fashion. And this would be an example of 4 tests that have been performed, and then the description of them, and then a summary diagnosis and guidance on therapy. We've already heard quite a bit about tailoring the tests of high-resolution manometry to the symptoms, and I completely agree with Rami and Andres and others about doing provocative testing. If you can repeat the symptom of chest pain or whatever the problem is, it's very useful. You don't really have to tailor a manometry test for reflux, but of course in reflux the reason for doing the test is often to define clearly the position of the lower esophageal sphincter, so that's worth documenting, and also whether the patient has or hasn't got a hiatus hernia on manometry, because sometimes that will differ from the endoscopic appearances, and that might make a difference to a surgical decision. I mentioned respiratory physicians. Well, they often send patients who have got cough, hoarseness, asthma, nocturnal choking, and of course these symptoms are hard to reproduce during the test, but if you're doing a symptom association, ask the patients to record if they've had any of these particular symptoms they were sent with, and then you can look for episodes of reflux. And dysphagia, of course, there's a lot of issues in dysphagia, so identify what the specific issue in dysphagia is, and if possible, particularly if you've got solid food dysphagia, try to make sure you do a solid bolus swallow. It's important to just consider previous procedures that cause dysmotility that might require surgery. So this, for a surgical audience, we all know that anti-reflux surgery, and in particular the Nissen, has a notoriety for causing dysphagia, but so too do other devices, and in fact the Lynx device probably causes more dysphagia than a Nissen does, as almost every patient will have dysphagia for the first 6 to 12 weeks, and they have to learn to swallow through that. But the LIX device also has some unique problems with erosion, encapsulation that will cause dysphagia. So if you're in a GI physiology lab, it's worth knowing about it. It's a magnetic bead band that is supposed to expand during a solid bolus swallow. But if the patient doesn't practice to swallow solid boluses in the first week, the fibrosis that develops around this band stops it from expanding. So they really need to learn that before they have their operation, that they have to swallow large lumps in the first 6 weeks to get the thing to expand. Other procedures that might require further surgery are bariatric surgery. We have a lot of these patients in our unit, and they have a variety of symptoms. For instance, dysphagia due to a tight band, or a stricture at an anastomosis of a bypass, or significant reflux post-sleeve gastrectomy. Sleeve gastrectomy induces a lot of problems. We had a discussion this morning about the IRP and the high gastric pressures. And post-sleeve, the gastric pressures are huge, and it's really hard to get what you might regard as a normal measure of an IRP in a post-sleeve patient. And Ivor Lewis I put in because these patients suffer significant degrees of reflux regurgitation and sometimes delayed gastric emptying. I would discourage people from referring them to GI physiology because A, they're all pretty terrible when you measure them, and B, there's not a lot you can do about it. If the symptoms are bad enough, you might do some kind of pyloric drainage procedure for the gastric emptying, but other than that, there's not much you can do. So I counsel against testing when there's not much you can do with the outcome. Dysphagia is a most important symptom in looking at manometry, and if the manometry is normal, and if the patient's had no previous surgery, it's worth your while as a GI physiologist to know that the patient could have eosinophilic esophagitis, because it is now probably the commonest cause of dysphagia, other than reflux itself, in our community. And your manometry may be normal, or it may show a degree of diffuse weak abnormalities. And if that's the case, and you're going back to a physician who may not be an expert gastroenterologist, you need to put in your report that the patient may not have had an endoscopy and biopsy for eosinophilic esophagitis. I put on the bottom of this slide, as well as a common cause of dysphagia, it's also a common cause of food bolus obstruction, and in fact it is the commonest cause of food bolus obstruction in our A&E departments. And so it's worth knowing that eosinophilic esophagitis, which used to be regarded as rare, is now relatively common. It is diagnosed simply by finding more than 15 eosinophils per high power field on an ordinary H&E section on any biopsy in the esophagus. And the reason for doing 6 is it's a patchy disorder, and you miss it if you just take 1. And just for your education, it looks like a variety of different abnormalities on endoscopy. So although you can sometimes see no abnormality, these days you usually, with good quality endoscopy, you usually see an abnormality. This is probably the most subtle. These are longitudinal furrows. And sometimes I show that to experienced gastroenterologists, and they laugh at me and they say, oh no, that's normal. And I'll then laugh back at them and say, no, it's not, it's EOE, and you've been ignoring them for the whole of your career. So this is a specific sign of eosinophilic esophagitis. If the patients have dysphagia, biopsy them, you find the condition, and then you treat them. This is the food bolus obstruction. This is a very advanced case where there are solid rings, and such a case would probably require therapeutic dilatation. And this is an unusual presentation of white patches. These are little micro abscesses of eosinophils. They're not candida. If you're used to looking at it with an endoscopy, you can spot the difference. So it's just a little education about eosinophilic esophagitis. Just moving back to high resolution manometry and the outcomes, I'm not going to repeat any of the good teaching you've had earlier today, but there are some specific abnormalities that will require some surgical treatment. And before I go into that, I just want to highlight that since the IRP is such an important indicator of the direction of our algorithm, it's really important to remember that the IRP varies depending on the type of equipment you use. So be very familiar with which equipment you've got and what your own normal values should be before pronouncing people abnormal with an IRP. And of course, the other area we look at specifically is the DCI, the contractility index, and that has some implications in how our patients are managed in terms of decision making for anti-reflux surgery, but not a lot. And I say this because traditionally people used to like the idea that they would tailor the anti-reflux surgery to the power of peristalsis, and it actually sounds like a good idea. But really, the manometry only helps to support the decision to have an operation, and it doesn't really make a difference to the type of surgery performed. So if it's normal, more than 400 millimeters of mercury second centimeters, then anything will do in terms of an operation type, and the statistics that you give a patient about the outcome of an operation for reflux is based on such patients. If they're a weak peristalsis, it may not make a difference to the type of operation because the outcomes don't seem to vary between one kind and another, but they are all a bit worse in terms of their dysphagia. So the patient has to acknowledge that if they've got a DCI that's between 100 and 400, they might be more likely to have dysphagia. And I'll tell you in a few minutes that dysphagia is actually relatively rare. So these patients, in these patients it should be less than 10%, and in these it might be up in as high as 30%. If they have almost no peristalsis visible, which is less than 100, it's a relative contraindication to doing the operation, but there are some surgeons who still get good results in scleroderma and other conditions. So we talk about anti-reflux operations and we give them names like Nissen fundoplication. Almost all the operations involve having the diaphragmatic crura brought together. This is the hiatus hernia, that is the esophagus just dissected sideways. And it's a very simple job to suture that to close the hiatus in most patients. And then this is what's called a wrap, a 360-degree wrap of the stomach around the esophagus. And that's a straightforward day case operation, which we standardized for the Lotus trial, and I will give you the results of that in a little while. Diagrammatically, this is what a Nissen looks like. It's all the way around, and then the other operations which are partial are called a toupee, which is a posterior partial wrap, and then there are anterior partial wraps, all equally effective if the surgeon has been well trained and he does the operation frequently. The real problem with anti-reflux operations is that they're sometimes done by infrequent operators. In our Lotus trial, we defined frequent as more than 25 per annum. Ideally, it should be more than 50 per annum. The surgeon should be doing it every week and be good at it. If he only does it 3 or 4 times a year, unlikely that they'll know what their outcomes are, and they may not be so good. So just to show you the results of anti-reflux surgery from the Lotus trial, it's not the world's best trial. It's not also the trial that is really what I would call our common day patient, because these patients were chosen only if they were tolerating their PPI and had a good result. In the trial centres, they decided it was unethical if a patient had residual symptoms to randomise them between surgery and PPI, because they should all get an operation. So these are only patients who are doing apparently well on their medication. And I would take some exception to Rabbi saying you exchange one symptom for another. You do cure reflux with anti-reflux surgery. It stops the reflux. So the heartburn that is continuing on your double dose PPI in as much as 25% of the patients almost disappears in patients treated with anti-reflux surgery, and that stays in the long term. Regurgitation is a commoner problem. It occurs in up to 30% of patients on medication because it doesn't stop regurgitation as such, but anti-reflux surgery almost completely stops regurgitation. Now, of course, the problem zone is the patients who get dysphagia. And in the first 6 months, it's common after anti-reflux surgery. 20% of patients will have dysphagia. And by the way, 50 to 60% of LINX patients will have dysphagia. But if they know that beforehand, they accept that. And actually, in my practice, within 6 weeks, it was disappearing really significantly. And at the end of 5 years, the dysphagia rate was actually statistically no different than being on PPI for 5 years. And the number of strictures that developed in the PPI patients was the same as the patients who had significant dysphagia for 5 years after anti-reflux surgery. So dysphagia in the hands of surgeons who do the procedure frequently is a relatively rare occurrence and not a problem. The single commonest symptom afterwards, however, is flatulence. Now, if you warn your patient about that beforehand, I don't believe it's exchanging one symptom for another, because most patients who have an operation have really troublesome reflux symptoms. And since everybody involved in the study has a 40 or 50% chance of having some flatulence, then for those patients who've had surgery and it's a little more frequent, it's not that big a problem for them. But they do have to be warned that they will fart a bit more because the air they swallow will not be burped. Rami went through some of the endoscopic procedures, and I'm going to make a comment or two about stretta and Esophagus, but the ones in the middle are simply things that have come and gone, and a lot of endoscopic operations, and I would call them operations and not medical treatment, because they're physical therapies. They've been popularized by physicians who seem to be afraid of surgeons or surgery, but they are in fact some form of surgical manipulation. Most of the endoscopic procedures do not last. The ones that are currently available are stretta. It's available in the NHS at a few centres. It has an effect on reducing symptoms, but very little effect on reducing reflux when it's measured. And it doesn't last very long, but it is applicable, particularly for patients who have troublesome symptoms, are on polypharmacy and need to be off their PPI, and perhaps are elderly and will get a short-term benefit from this, and that's the group that are mostly getting stretta. Esophagus and various other endoscopic applications are being researched, but in no hands yet has anybody published a series where the data shows that it's effective for longer than 6 to 12 months, and it is not a simple procedure to do. It takes much longer than doing a Nissen fund application to do one of these endoscopic procedures. So they're expensive and they don't work very well, but they're probably worth developing in research centres. I've mentioned the magnetic bead band as an alternative form of surgical intervention. This is another one. This is potentially a therapy that might be good for the patient with no peristalsis. It's it's called endostim. It's an electrical stimulator of the lower esophageal sphincter. It works by neuromodulation, not by muscle stimulation, and it may have a role in the future, but it too has to undergo further research. I won't dwell either on the treatment of achalasia too much. You've heard about these definitions of the different types of achalasia. The therapy involves pneumatic dilatation, and the one comment I would make about the size of the dilator is please think about the size of the patient you're treating. So it really kind of irritates me that somebody wouldn't ever go to 40 millimeters. If you've got a rugby player who's 6'4" and he's 20 stone and he gets achalasia, well, he probably needs some Heller's myotomy. But if you're going to treat him medically, he'll need a 40 millimeter balloon. If you've got a little old lady and she's only about 5 stone and she's about 5 foot tall, there's no way she needs a 40 millimeter balloon, it'll burst her. So would you make your decisions based on the size of the patient as well as the clinical outcome? And I think you'll then find that you're tailoring your therapy to the circumstance that you're treating. Laparoscopy Heller's myotomy, I would take some exception to Rami. He said it was a painful operation that required a long-term hospital stay. 95% of my Hellers are day cases. They're home the same day, they're back to work 3 days later. They don't have pain, and they make very good recovery, and because they all get a door fund application, they don't have long-term reflux. So that's quite a tall order to compare the poem to. And poem itself, well, we don't really know the long-term results yet. It's relatively new in this country, although there are 8 to 10 years experience in other countries, and Botox is no benefit. I think the most important message on myotomy is that achalasia is a rare disease, therefore the treatment of it is rarely done, so it should be done in specialised centres. And it may be that your centre has a very good endoscopist who does a very good poem, and may not have surgeons who do very good Hellers. So in that circumstance, poem becomes the optimal procedure. So it depends as much on what's available and expertise as anything else. And as Rami said, medications of limited value. This operation is easy to do in an expert hand. It's fun to do. You clearly see what's going on. It's very quick because you don't have any trouble working out what the anatomy is. And this is what a door fund application looks at the end. And the long-term results of comparing achalasia treatment just depend a lot on the specific studies that you look at. And certainly the perforation rates recorded in some of the medical trials, they had to adapt what they were doing to do this graded increase and taking some time, because in order to have the same success as surgery, they did need to dilate to a wider diameter, but they needed to do it in stages. And just on the issue of how to do a dilatation, we published last year the guidelines for the BSG on therapeutic dilatation, and some comments were made about the method of doing dilatation. It's worth reading what's in the guideline. POEM outcomes, the one thing I would say is that they do show a high rate of reflux, and while it's not the be-all and end-all, it does mean the patient is required to take medication. Most of these patients who have reflux documented are on full-dose PPI, so they are transferring one disease to another. Although I would say that both POEM and myotomy produce a better quality of life in terms of the patient's ability to eat solid food for a long period of time. It's been mentioned that there are 3 types, and just as Rami said, the type 3 achalasia, they're ones that deserve a myotomy perhaps earlier in your mind than the others do, where dilatation might be an early option. So myotomy is preferred for type 3 because there's such poor results with dilatation. And the other motility disorders, that's the ones that are ineffective motility and fragmented peristalsis. They have no surgical interventions because they're really not disorders that have a significant quality of life issue. But there are some therapies that are worth considering for jackhammer. You've heard Rami describe it, and the medical treatments. And all I'll say is that some of those patients, as long as they've been through the medical algorithm, which in my hands cures most of them anyway, so very few of them really need a myotomy, and then I think a Heller's is effective in them, as my Heller's can go well up the esophagus. But a POEM is also a good idea, and having a longer myotomy is an option for some of those patients. Now the issue of pressurization, and in particular the EGJ junction obstruction, is an important issue that's been mentioned. Certainly in our lab, this is a commonly identified abnormality now that we've got high resolution manometry, which is something we never saw before. And so knowing your normal IRP values and then understanding why you should have a raised IRP is very important. This is a patient who doesn't particularly have a raised IRP, but on multiple rapid swallows and solid swallows developed increasing pressurization in their esophagus. And so they had a degree of obstruction. I think in this particular patient, it turned out that after a repeat endoscopic ultrasound, they had an adenocarcinoma at their lower esophagus that wasn't visible. And EGJ obstruction, one of the causes for it is a submucosal cancer that's not visible by endoscopy. So that's called pseudoachalasia. So it's worth knowing that you should do an EUS to try and identify it. Other causes are a gastric band after bariatric surgery, perhaps too tight an operation for reflux, functional disorders, and it has already been mentioned about narcotic use by a couple of our speakers. This is a hugely frequent problem, and so in our laboratory, the commonest cause of EGJ obstruction is people taking opiates, either a patch for pain or chronic morphine, or codeine for a cough, and so it's really worthwhile knowing about this. Now, they don't have to stop the medication, but you can at least identify for the patient and their referring doctor that the cause of their dysphagia is EGJ obstruction, which is caused by the narcotic. Now you choose, do you stop your narcotic and have your pain back, or do you keep going with the narcotic and at least understand why you've got your dysphagia? Right, interpreting pH monitoring and what to do about it. I just want to highlight that traditionally we've used the Demeester score as an all-encompassing figure, but I think we should always report the total reflux time percentage, and you should be aware of what your own normal ranges are. The positive symptom association is very useful for surgeons making a decision. If there isn't a good symptom correlation, then one should worry that maybe the symptoms are coming from something else. And if you're doing symptom associations, be careful about false negative rates. You need to have at least 12 symptoms for reliability doing this test. A low symptom index is associated with poor reflux sensitivity, and actually that's common in Barrett's esophagus. So our patients with really bad reflux who have Barrett's often don't feel their episodes of reflux that often. And the SAP is a statistical test that requires more than 80% association with a p-value less than 0.05, and you need to understand that. And small changes in the number of episodes felt to make a large change to the SAP. So just be conscious of that and always report the number of symptoms which you used to calculate your symptom association probability. I think impedance monitoring is very useful when looking at patients with reflux symptoms, because it helps to identify things like belching. Belching can be treated with non-surgical means, physiotherapy, breathing exercises, diaphragmatic control. Aerophagia is another thing that can be identified with impedance monitoring, and that should be treated with speech therapy using your speech and language therapists, and sometimes biofeedback and sometimes hypnotherapy. These are really useful things. I've had patients come to me wanting an anti-reflux operation because they reflux terribly, and they've had 2 or 3 pH tests. I did an impedance test on 2 that I can remember, and I said, no, I'm not going to operate on you. You simply swallow too much air, and send them to ENT or a speech and language therapist. They look at you with shock because they think you're going to do an operation, but then they come back and see you 6 weeks later and they say, gosh, that fixed the problem. I won't go into the functional disorders, but I'd just like to highlight this particular paper to you. It's a very useful description of the Rome 4 criteria. It was about all of functional gut syndromes, but this edition in 2016 focused on upper GI symptoms, particularly functional heartburn, chest pain and dysphagia, and is very useful to refer to. But I'm not going to go through that, as I was indicated to speak about surgery. And I just want to give you a flavour for what we find. So in a laboratory like ours, over a period of time, I just looked at roughly 100 consecutive cases. We only found normal in about a quarter of them, and some of those had dysphagia, and 5 of those patients actually we sent back to endoscopy, and they were found to have eosinophilic esophagitis. We had about 30% who had reflux with normal motility, and another 20% that had reflux but with a non-specific dysmotility. So that is our commonest diagnosis. And then we have some with a non-specific dysmotility but no reflux, but that's a pretty rare circumstance. We had only 9 out of about 100 patients where we had a major dysmotility disorder, of which the commonest was an OGJ obstruction. So these are relatively rare events, even though we talk about them quite a lot. We had 9 patients sent back for Nissen review during this period of time, and I am readily keen to do post-operative testing in our Nissens, because if they've got any symptoms, it's worth testing. And we were able to tell 6 of them that it was completely normal. 2 of them had some degree of obstruction, and 1 of them had a recurrent reflux. 4 patients in this 100 series had bariatric complications. It's my perception that this is getting more frequent as time goes on. And then the issue that we had is 2 of our patients who had their physiology tests were technical failures. And I'd just like to remind you all to try and benchmark the number of failures you've got. I don't think any physiology lab is 100% successful at sticking these uncomfortable tubes down people's noses. So there will be a degree of failure in any laboratory. And if you can be below 5%, I think that's quite acceptable. I think if more than 10% of your patients are not coping, then you perhaps need some degree of modification of what you're doing in order to make the tests more acceptable. So my take-home message is the outcomes of your tests should redirect investigations such as endoscopy or EUS, medical therapies, predominantly for the motilities, stopping medical therapy, so if patients don't have reflux, you can stop the PPI, involve other disciplines. It could perhaps indicate interventional endoscopy. It can sometimes indicate surgery. And this is just a useful take-home slide to remember the outcomes of your testing are really far-reaching and varied and involve lots of other people. So you need to educate them all into why they are doing what they're doing. Thank you very much.